Hello, everyone. Thank you all so much for coming. Welcome to Health for the World's International Grand Rounds on December 3rd. Today, we are very lucky to be joined by an expert discussant in cardiology, Dr. Gene Kwan. Dr. Kwan attended medical school at UC San Diego School of Medicine. He then went on to complete residency in internal medicine at Brigham and Women's in Boston. Afterwards, he completed a fellowship in cardiovascular medicine at Boston University Medical Center. At present, he holds the title of assistant professor in cardiovascular medicine. And within the cardiovascular space, he has been a leader in helping us better understand global cardiovascular outcomes and improving delivery of care and other resources to low and middle income countries. Again, Dr. Kwan, we are so honored to have you with us today, and you can begin whenever you're ready.
Great. Well, thank you very much for the opportunity. Yeah, it was really fun actually just learning about the work that this organization is doing and actually the communities to which it's connected. I know in this webinar format, I'm not sure how interactive this can be or what's possible with our technology, but um, yeah, I hope for anyone to pause at any time, ask questions if you're able. I think we'll have some time at the end as well. Yeah, it's great to see our colleagues from Cameroon here and um, uh, yeah, and throughout the world, either joining right here, right now, or in the future, I guess, through the webinar and through the YouTube platform. As was mentioned, I'm a cardiologist, an adult cardiologist, working at Boston Medical Center and Boston University. And for the last 15 plus years or so, my work has really been in trying to improve access to care for heart failure, particularly in rural Rwanda, rural Haiti, as well as rural Malawi and rural Liberia, together with an NGO called Partners in Health. Partners in Health was really formed to bring care to the people who otherwise couldn't access it, and that oftentimes is in the most remote places in the most challenging countries. So I think for our colleagues here in Cameroon, I'm hoping a lot of this resonates with your experience, and feel free to kind of add in your own observations and kind of how you've seen the health systems work well for patients or even not work well for patients, because there's a lot that we can do. First, so I'm going to talk about our approach to improving heart failure care, really thinking about how to use the resources that we have and that are available, and some challenges that we've experienced, and kind of opportunities for you to consider doing some of these as well. Just looking from the prior webinar topics, this may be a little bit different some of the others, where they're more kind of based on either a different disease process or imaging modality. But here, this will be a little bit more broad. So first, I'll talk with you about a case, and I think a case like this isn't going to be that foreign to you all. Let's see, get this one going. Yeah, so this is, so I'll introduce you first to Valder. Yeah, this is Valder. Valder is, when I met him, he was 16 years old. He lived in rural Haiti. At that time, at age 16, he only weighed about 30 kilos. And he had shortness of breath even when walking around his home. And this is home, this is where Valder lived. And here's some of Valder's family. Close this other window here. This is Valder's family. You can see Valder next to his father. And at age 16, you think most, young men, adolescent boys are about to reach their full adult potential in terms of height. You can see how stunted in height Valder is compared with his father. And where Valder lived happened to be in Haiti. And he lives in a very hilly part of the country. The country itself has 10 million people. There's only about 16 cardiologists who all work in the capital city. And in Haiti, there's only about 2 doctors per 10,000 people. And so when we saw Valder, he came to our clinic in rural Haiti with, let's see, can I get this to play? Oh, it's not playing. Not sure why. I'm sorry. May be challenging. All right, so we did an echocardiogram, and on this echocardiogram, this is the left ventricle, the left atrium. This is the mitral valve, and his mitral valve was very thickened, very very thickened, very calcified. This is the ravages of rheumatic heart disease, a disease that we don't see very often here in the United States, but it's actually the leading cause of acquired heart disease worldwide. And so Valder presented to a clinic in Haiti, and if we follow what the global dialogue around chronic disease has been, he would have encountered things like this. Over the last decade or so, groups are publishing about what the challenges in chronic non-communicable diseases are, and really promoting this is an issue of smoking, this is an issue of unhealthy diet, lifestyle, and obesity that's causing the epidemic of heart disease worldwide. And the United Nations, the World Heart Federation, the World Health Organization, all these global bodies have targets and commitments to help to reduce the scourge of cardiovascular diseases by doing things like this: reducing alcohol, reducing physical inactivity, lowering salt intake, targeting tobacco, improving blood pressure, and not having any worsening of diabetes on the population level. And these all get packaged together by our WHO colleagues into something called PEN, or PEN, which stands for the Package of Essential NCD Interventions. This term NCD is for non-communicable diseases for primary care. This is a package of multiple things. The bulk of it is for cardiovascular disease, and it focuses on reducing cardiovascular disease risk in people aged more than 40 years old through things like lifestyle counseling, treating hypertension, and statins for cholesterol. Sorry, I was hearing a voice there. Is there a question? Okay. If there is a question, just keep talking, and then I'll eventually hear it, and then I can stop. So this is the bulk of what the package of essential NCD interventions is for health centers. It packages this together with interventions for diabetes as well as lung disease and some other things for health promotion. But if Valder presented to a clinic like this, he would be left out, right? He would be left out of this particular package, because package of essential NCD interventions is not really for symptomatic heart disease, not for heart failure, not for the young, not for rheumatic heart disease. So the current interventions pursued at a policy level wouldn't reach patients like Valder. And Valder is not alone. So as you guys know, heart failure, what is it? What does the heart do? The heart pumps blood to the rest of the body. Some of these slides and figures are taken from a patient education resource that we've developed, where we try to teach patients about what heart failure is. So to simplify it, the heart is a pump that pumps blood to the rest of the body, and heart failure is a chronic condition, meaning it can't be cured, but it can be controlled with medicines, as you know. And when the heart is weak, it cannot pump enough blood for the body's needs. It can be a chronic condition, so a patient has a long road and a long journey. This weakness of the heart causes the body to retain fluid. That fluid builds up in different places, whether it's in the lungs, causing shortness of breath, or in the feet, causing leg edema. It's not really transmissible from person to person in general, although specific causes like rheumatic heart disease, the underlying causes can be transmitted person to person. So it's an example of a communicable, non-communicable disease. And then what causes heart failure? Well, there are, in high-income countries, you see a lot of coronary artery disease, cholesterol plaque buildup in the heart arteries that can affect the heart muscle. Our particular patient has a faulty heart valve from rheumatic heart disease. Having uncontrolled high blood pressure can cause heart failure, as well as diseases of the muscle itself, or cardiomyopathies. And as a syndrome, heart failure causes a lot of different symptoms, some of which may be caused by other conditions too. It can cause shortness of breath, for which there are a lot of different causes, not just within heart disease, but lung disease, severe anemia, endocrine disorders. A lot of those things can cause shortness of breath. Swelling of the feet or legs, which you can also see in nephrotic syndrome and kidney disease, as well as advanced cirrhotic disease. Those are other conditions causing leg swelling. difficulty sleeping or laying flat with orthopnea, fatigue and low energy, persistent cough, as well as sometimes chest pain with palpitations, rapid and strong heartbeats. But for all of these symptoms together, it takes an astute clinician to recognize that these symptoms in combination represent heart failure. And so that's where we go from a patient with shortness of breath presenting with heart failure symptoms to getting a diagnosis. And the vast majority of the time, a diagnosis really relies on echocardiography. So it'll require a patient to get acquisition of echocardiography images. Those images then need to be interpreted, and that interpretation integrated into a treatment decision where patients can then get their medicines. But there's challenges at each of these levels. Either heart failure may not be recognized at presentation. I've been to a lot of health centers where we see patients with shortness of breath given inhalers, and then you have cases of bronchodilator resistant asthma, which ends up not being asthma at all. So heart failure may not be recognized when it first presents. For acquiring echo images, there may not be enough cardiologists, or they may be too far away, or the wait time too long, presenting large barriers for patients. The echo images need to be interpreted, so the cardiac pathology may not be recognized, or you may have misdiagnoses. And then that will need to be integrated into treatment decisions, and provider skills may not be up to date with the latest evidence-based therapies for heart failure. And to think about how to approach these, we must first think about what causes heart failure in a place like Cameroon or a place like Nepal. And these are 3 studies from 3 different countries our team has done in Haiti, Rwanda, and rural India, where we evaluated patients with heart failure and assigned them a category. The vast majority, which was in the orange, is in this cardiomyopathies category. The next largest group were in the yellow, were these rheumatic heart disease categories. In the green, many patients also presenting with right heart failure from severe lung disease. In this light blue, patients with hypertensive heart disease. And depending on the age and the location, we had a lot of patients in this gray zone with congenital heart disease, and then very few people with other types of heart disease. So we're really dealing with a combination of cardiomyopathies, rheumatic heart disease, right heart failure, hypertensive heart disease, congenital heart disease. And there are different conditions related to poverty that can promote these types of heart diseases. For cardiomyopathies, they can be underlying cause could be things like HIV, other viruses like coronaviruses or enteroviruses, Chagas disease, particularly in South America, micronutrient deficiencies. There can be genetic predispositions also to developing cardiomyopathy. Another specific type of cardiomyopathy is peripartum cardiomyopathy. Among people who have women who have multiple pregnancies, confounded with malnutrition and lack of family planning access, that can increase the risk of peripartum cardiomyopathy. Rheumatic heart disease, like in our patient Valder, having recurrent group A streptococcal pharyngitis, living in crowded conditions, lack of basic access to primary care, lack of penicillin, lack of recognition of strep pharyngitis and treatment of that at primary level can lead to rheumatic heart disease. Congenital heart disease, there are different infections like maternal rubella, as well as other micronutrient deficiencies that can lead to congenital heart disease. And then amongst right heart failures, having ambient or indoor air pollution sometimes from cooking fuel and cooking smoke, whether wood fuel is used or gas fuel is used in places that don't have proper ventilation, that can lead to lung disease resulting in right heart failure. Tuberculosis that is poorly treated or treated late can lead to lung disease causing right heart failure, also schistosomiasis. And then pericardial disease, primarily we'll see it from tuberculosis or advanced malignancies, particularly breast cancer, can cause pericardial disease. And so our patients in rural Rwanda, rural Haiti, tend to be those who are farmers. They're very physically active. There's very little rates of obesity, but patients are living in crowded conditions, poor housing conditions. But many people with heart failure may feel either too sick to work and have to borrow money or sell belongings to pay for their healthcare. So it leads to a lot of challenges and barriers to achieving the cardiac care that they need. And in the countries where I've worked, there are very few cardiologists all working in the urban settings. But in most of these countries, most of the population lives rurally. So 80% of the populations in Haiti, Rwanda, Liberia, they all live in rural regions far from where the cardiologists are. And in Rwanda, for example, there's 6 cardiologists for about 12 million people. Liberia have none. We're training the first 2 cardiologists now. Malawi just has 1. We're trying to train some others. As contrast, in Boston Medical Center or Boston itself, we probably have about 300 cardiologists in our city, in our metropolitan area, for only 5 million people. And so access to cardiologists can be very challenging. And our group has actually used the existing health resources, which are primarily nurses at the district hospital level or first referral hospital level, to deliver some cardiac care. And so our group has done this. We've divided most common heart failure into 6 different diagnosis and treatment categories using a combination of echo and physical exam findings. Where first we ask providers to do a basic echocardiogram to identify very simple abnormalities, and then use that to categorize people into a diagnostic category. For example, those with reduced left ventricle systolic function will have a diagnosis of cardiomyopathy. Those with very specific mitral valve features on echo will be categorized as having mitral stenosis. Those having severe hypertension will consider having hypertensive heart disease. And if that's still normal, those with a loud murmur will be in this category of other valvular or congenital heart disease. And those with a dilated right ventricle will be in this right heart failure category. And those with a large pericardial effusion will be in this pericardial disease category. In each of these treatment categories will have diagnostic categories will have their own treatment. Patients with cardiomyopathy need to be on evidence-based medicines, including ACE inhibitors or angiotensin receptor blockers, beta blockers, spironolactone, furosemide to help with the symptoms. Those with mitral stenosis from rheumatic heart disease should be on a beta blocker to lower the heart rate and improve symptoms, as well as penicillin to prevent progression of the rheumatic heart disease, and furosemide. Those with hypertensive heart disease need a diuretic, as well as medicines to control the blood pressure. Those with other valvular congenital heart disease really need to see the cardiologist to identify what specific valve abnormality or congenital shunt they may have. So that takes will require additional training and additional referral to a specialist. Those with right heart failure, it's really about treating the volume with furosemide and treating the underlying lung disease. And with those with pericardial disease, those will be need to referred for pericardiocentesis if you suspect tamponade. So with this, we've been able to take very basic findings on echocardiography, help clinicians categorize patients into one of these 6 major diagnostic categories, and from there, help with identifying what the treatments should be. And this is really to help patients get on treatment earlier when they're seen at a district hospital. That way they can have started the treatment already while they're still waiting to see the cardiologist, instead of having to wait additional months, spend additional money before they can start getting the treatment that they needed. So it really speeds up the time to care. So these are some characteristic echocardiographic findings. This is an example of here on this echocardiogram. These are all parasternal long axis views, but this left ventricle systolic function is very, very low. So you can see that the left ventricle wall is coming very, very minimally. So this patient is very low ejection fraction, characteristic of cardiomyopathy. This other patient here in this parasternal long axis, the left ventricle looks normal or small, but the right ventricle is actually very dilated. Actually, this one also has mitral valve disease. This is similar to Valder's, where the mitral valve is very thick and calcified. has restricted motion. There are characteristic abnormalities here that we see in rheumatic heart disease. This other one here, the left ventricle function is normal and the mitral valve look normal. But going down our protocol, the abnormality is that the right ventricle is very dilated, which we see in right heart failure. And this fourth one, normal left ventricle systolic function, the mitral valve looks normal, the right ventricle is normal size. This patient has elevated blood pressure, which would be in the hypertensive heart disease category. Yeah, so combining your echo findings with some basic physical exam findings can really go a long way to helping to diagnose what condition or what kind of heart disease a patient has, so that you can start evidence-based medicine earlier rather than just waiting for the cardiologist to see them. So we've done training for basic echocardiography in a number of countries where we teach others the skills of image acquisition, image interpretation, as well as integrating that interpretation into clinical management. Here is an example. This is Dr. Rusingiza, one of our pediatric cardiologists in Rwanda, training several nurses here in echocardiography using portable devices. Since then, portable devices, I'm not sure what you all have there in Cameroon, have gotten much smaller, much more portable, much more robust. Our total training in the past has been 2 months for an integrated non-communicable disease package that, in addition to heart failure, is diabetes, hypertension, and respiratory disease. A couple of days a week are specifically for heart failure, and they have a number of sessions with the expert to help train them. But it's particularly resource intensive, but it does. So we've been able to train nurses in Rwanda to be able to do these basic echocardiograms to diagnose heart failure of different categories with pretty high sensitivity and specificity and high agreement with a cardiologist. And then, so we're able to do this. I guess the next question is, where should we do this? At what level of the health center? And Rwanda's health center is very decentralized. I'm not sure how the health system in Cameroon is structured, but Rwanda is divided into about 40 districts, which are these orange zones. Each district is divided into subgroups or kind of subdivisions, each with its own health center. And this one here has about 12 health centers that all refer to one hospital. And each of these health centers serves a population of about 10 to 15,000 people. And so we've integrated this care, and so having this number of people in a catchment area for a health center actually wouldn't give that many heart failure patients. So if you train someone just at a health center to do heart failure only, a lot of their time they'd be waiting around for patients to show up. So we've actually integrated this care into the first referral level, the hospital level at the district, in something that we've called PEN Plus. And so I told you what PEN is. That's the package of essential NCD conditions, which is designed as a health center-based intervention. PEN Plus is really a first level hospital or district hospital intervention where we'll train providers in more advanced skills, things like echocardiography, basic EKG for arrhythmia, for identifying atrial fibrillation, X-rays. They'll need other medicines that may not be available at health center, things like diuretics, medicines for heart rate control, anticoagulation if they need it for blood thinning, and then also refer people for cardiac surgery to the referral center or to see the cardiologist if they need further diagnoses. So we've packaged this at first referral hospital level where we've trained nurses to be able to do these echocardiograms. And so we've taken novice trainees and with a cardiologist, trained them, and then they've been able to provide clinical care. This is a photo of one of our first trainings that we've done. But over time, as you know, health staff may transition even within the health center. And so These three in the blue have been promoted to administrative roles. They're still involved in heart failure programs, but they don't deliver care directly. All these ones in the red have actually been reassigned either within the same hospital or even to different hospitals. So they're not using the same echocardiography skills that we trained them in. And Francis in the green is our lone one that's still practicing his trade using echocardiograms. So to train others, we've taken those who had delivered clinical care and developed clinical experience and gave them a training of trainers where together with a cardiologist, we've trained them to be master trainers. And then these master trainers have gone on to train more novices who then provide clinical care. In Rwanda and other places, we just don't have enough cardiologists to do the amount of training that we've needed. So we've really focused in on this master trainer model here. We've also added e-learning modules, which are computer-based that teach about heart failure physiology and management. They have interactive features to really promote the engagement, and we've really replaced the didactics in our training and flipped the classroom where we have our providers kind of do these modules before we get together as a group, and then our nurses can then help teach each other as this nurse Nasan is doing here. So with our new training structure, we have pre-work where the trainees look at e-learning modules and learn from those. Then there's group work sessions where the trainees teach each other about cases, and then practical experience where they perform echocardiograms, some of which is precepted by an expert, some of which is independent practice. They have to scan at least 25 people and then interpret 50 echocardiograms, some of them from a video library that we have, and then pass a written test. And with this model, we've been able to train many nurses in Rwanda, hitting all 40 of the district hospitals over a matter of a number of years. And with this, having nurses treat heart failure, we've been able to improve proportion of people on different medicines, on evidence-based medicines, for example, on beta blockers, ACE inhibitors, and loop diuretics for rheumatic heart disease, making sure we have 90% of people on penicillin and about 3/4 that have gotten referred for cardiologist evaluation using this. In Rwanda, compared to Haiti, for example, we had a new program in Haiti where only about 21% of cardiomyopathy patients were getting medications from 3 different categories. But in Rwanda, after a number of years, that proportion has gone up to about 60%. So still room to grow and improve, but definitely making improvements in a program that's really delivered by nurses and not cardiologists and not physicians. That way, it leaves a lot of the effort for physicians to be able to care for the more challenging cases and to be able to provide mentorship to the nurses. But even with having a decentralized program like this, where you try to bring the care closer to where the patients are at the hospitals, we've experienced very low linkage of care among heart failure patients. So in a study in rural Haiti, among patients with heart failure, we found in the purple bars, these are the number of people with heart failure, there were about 300 admitted with heart failure, 270 died, so about 11% died in the hospital. But only 99, which is about 36%, actually had a clinic visit within 30 days of when they left. And they tend to leave the hospital with 30 days of medicines. And so if you're not coming back to the facility, then you're going without medicines. And even fewer have a second visit within the next 90 days. So we're, even though there's a lot of heart failure cases coming to the hospital, very few of them are coming back for care. And in Haiti, we actually asked people why it was that you weren't coming back for care. And so we did a qualitative study with interviews among patients, trying to understand what were the facilitators and what were the barriers to chronic cardiac care. We organized it using something called the socio-ecological model, where you have different concentric levels for individual, for interpersonal or social networks, the next one being the organization or the health system, and then finally the community or spiritual beliefs. And at the individual level, patients would say that I find help at the hospital, and that's the reason why I'm alive today. So patients really had knowledge of the importance of coming to the hospital, prior positive experiences at the hospital. But they also reported some barriers, saying that sometimes I would spend the whole day without food and I cannot take medicines. So having food insecurity was a major thing. Um, I think a lot of patients were actually told that they had to take, or had this belief that they had to take their medicines together with food. So in times when they were food insecure and didn't have breakfast food, they would just not take their medicines in the morning. Um, while with some medicines, taking them together with food may decrease some of the side effects, for a lot of cardiac medicines, they don't really have those GI side effects. So that's something that is a misconception that we could target through education. At the interpersonal level, patients would say that I have a heart problem, but my children take care of me. So emphasizing the importance of having a social network, having other people that you can rely on to really help you with your chronic disease, because it's hard to do this by yourself. But one barrier at this level is that patients would say, I've been sick for the past 2 years and no one comes to visit or ask about me. Being sick can sometimes be very isolating, leading to feelings of abandonment. And so really strengthening the social network can help restore the soul to some degree, to help ensure patients get the are able to kind of navigate the care that they need. Because oftentimes it's family members that help patients come to the hospital, as you all have seen. At the organizational level, patients may have said that since I've been taking my medicines, they make me feel much better. So there's this experience of this past experience of having medicines and knowing that the medicines help, but also having a system, a health system where they're able to access medicines, where medicines are available, hopefully low cost, and having low clinic fees, particularly for chronic conditions where you have to come very frequently. But some patients did say that sometimes the transportation fee prevents me from coming to the clinic. Patients live far away from hospitals and health centers. Getting there can be challenging, it can be expensive. That can be itself a barrier to actually coming to the hospital. So even though somebody knows that they need to come, has experienced prior positive improvements, just coming to the health center and getting the medicines can be difficult. At the community level, some patients said that, I came here to the hospital and I found good treatment, but it's because of God. So there may be the sense that there are higher powers that, have made it such that the patient and the health system can come together at the same place at the same time. Thinking that the way life happens is an extension of their spirituality. But also sometimes patients may say, particularly in Haiti, they'd say that heart failure originates from mystical spirits, from something called a habitation, which is like there's some supernatural spirit that caused them to have heart failure. I have it because of this spirit. I'm not sure I can get this spirit to go away, but it's something that I have to live with. And so sometimes as providers, understanding where patients come from and what their worldview is and their understanding of their disease process can help us to care for them the way that they need. So even identifying some of these factors, we've been able to try to address some of these misconceptions, try to reorganize health systems to be able to be more responsive to our patients with heart failure. But even with what we're doing, we're finding that the most well-off patients are the ones who are engaged in care. And there's a study where we assess the wealth level of our patients and categorize them either into the poorest category of patients or the least poor category of patients. And we found that those in the least poor, the most wealthy groups, were the ones who were coming to the clinic, whereas those who are the poorest were the ones who are not coming to the clinic, and shows that disease is not distributed evenly across wealth, and there may be barriers related to poverty affecting the people who couldn't come. And in identifying where our patients are coming from, this particular facility is this H here in rural Haiti. The capital of Haiti is down here in the star. So this hospital is about an hour and a half drive away. But a lot of the patients come even from far away, and there's a road that goes this diagonally here, and a lot of the patients are coming along this road, but patients are coming from the more kind of semi-urban areas, even here from the capital center, coming an hour and a half to the hospital in a rural region. And there are people from rural regions who really need care, but sometimes are not able to access it. We've tried to address some of these misconceptions through empowering patients through knowledge and doing education with patients. I think that this helps to improve patient adherence. For chronic respiratory diseases, using an inhaler or using injectable medicine like insulin can be very challenging. And that's what we've been able to do through patient education in several of our countries, as well as increasing patient retention. Because then there's this understanding of the importance of heart failure as a chronic disease and how it needs chronic care for follow-up. And so we've been able to integrate this education into our programs. And this is Francis. He's the nurse I said that we trained long ago who's still working with us. And he says that it's the main reason our patients keep coming back. And they say that you pay attention to us, particularly when we're taking time to teach them about their condition. We work as a group called the Non-Communicable Diseases and Injuries of Poverty Network. We've been working with a lot of different countries on a 4-phase plan towards improving access to heart failure care through this PEN Plus model. I see Cameroon here in red. Our red category is really working with Ministry of Health leaders and leaders of health systems and other key stakeholders to really analyze the situation and set priorities for what chronic conditions should be targeted and need to be targeted. And then those in the orange are in a delivery model design where we work and try to figure out, all right, in the context of your health system and and what targets you want to address, how can we develop a delivery model that is contextually appropriate? And then our phase 3 countries are those that are doing initial implementation. So after you've designed a model, you can implement it in 1 or 2 places. And our countries where we've been doing this the longest are in this phase 4, where we've not only done it in 1 or 2 places, but we've shown that it works. And now we're working with hospital leaders to try to figure out how to scale this up beyond just our initial implementation. So we've been doing this type of work with using task shifting to help improve access to care for heart failure, but there are still a lot of challenges for diagnosis. Rural patients still cannot access enough cardiologists, but we're doing echocardiography training for frontline clinicians. That way patients can be referred to the specialists when they need them. As well as there are heterogeneous causes for heart failure, lots of different causes of heart failure. Heart failure is not one condition, but a group of many individual diseases that have the same collection of symptoms and signs. And we've tried to target that by simplifying the diagnosis for heart failure and having diagnostic and treatment categories. We've seen that there's low use and adoption of evidence-based medicines for heart failure, and we've tried to simplify the management protocols, incorporate mentorship to improve access and improve the skills of providers. Also, there are just not enough experts for training, and we've tried to address this by training master trainers, using other technologies for clinical education, like the e-learning modules I mentioned. There are also simulators to help train echocardiography. At the patient level, there has been low linkage to care and low retention in care. And so we're working on different patient engagement strategies, whether that's doing phone calls, using text messages, trying to do community health worker strategies to improve connection with the health facilities. Also, we've noticed some patients will stop their medicines when they're feeling well. So as you take medicines for a heart condition, you feel better, unlike acute care problems or infection problems where once you feel better, you don't need to take the medicines anymore. For chronic conditions, as you know, patients need to continue taking them to keep feeling well. And that's where patient education can be so important. On the policy level, there's relatively low priority by international stakeholders for cardiac care, for heart care, in part because it's very prevalent. It's very, and trying to figure out financing for this is very challenging, but helping local settings set priorities for conditions affecting those who are young or those who are poor, those who really need the care the most, that have the most to benefit, and really lead you to taking care of these patients with heart failure. Also, there have been a lot of vertical disease specific approaches. So HIV specific clinics or TB specific clinics or type 1 diabetes clinics or sickle cell clinics. Our approach has been to integrate these all together because they share some commonalities as they're all chronic conditions. They have specific training needs and specific care needs, but there are some common features amongst all of them. Right, so this has been our approach to cardiac disease care and heart failure care. We've done a lot of work, but there's a lot more to go. And you can visit us at this website here. Feel free to email me if you have any questions. And yeah, happy to hear how kind of your approach to heart failure care has been, or kind of your experience with what it's like for patients either in the urban settings or rural settings are to achieve the cardiac care that they need. Yeah, thank you.
Excellent. Thank you so much, Dr. Kwan. That was fantastic and I think very timely and needed. At this time, we will open up the floor for some questions from our panelists, and afterwards we can answer any questions in the Q&A section from any of our other attendees.
Hello. Hi.
Hello, Doctor.
Hi, Dr.
Hi.
Maskey.
Yeah, I am from Nepal. It was a very excellent talk, Dr. Jean. And whatever you have presented is mostly like we are from eastern part of Nepal, and it has a population of around 16 million. So like is and whatever you are telling like Pen Plus. So we are also having Pen Plus program in Nepal, and there is a village or town called Damak here for around 1 hour drive from here, and the center is developed by Professor Bhawan Korela. And so I am being an endocrinologist. I am running up. I am going there as a mentor, and we are like this community program and training the junior doctors, house officer, nurses are really useful. So your program and our professor from cardiology, Dr. Professor Sani Sharma, is also involved in this Pen Plus, and he's involved in the cardiology, and he's doing the echo, the handle echo, and all. So the situation and the study you did in your part is is matching with us also, but we are yet to come out with the studies. So you have told nicely regarding the heart failure treatment with the three drugs like diuretics, CCB, and AC inhibitor. So have you used AC inhibitor and ARB as a RAS blockade in heart failure, and what was your experience? Because there is a problem in seeing the sodium potassium and you have to see the doubling of creatinine after 3 days. So what is the experience on such issues? Can you share us with us?
Yeah, thank you, Dr. Maskey. Thank you for your support for this. Dr. Kerala in Nepal has been a big champion of Pen Plus. For those of you who don't know, Dr. Kerala is a cardiac surgeon, and he was seeing a lot of patients with rheumatic heart disease, seeing the challenges that the poor patients were going through, and through his efforts was able to work very strongly with the government of Nepal to develop like a national program for paying for surgery for rheumatic heart disease, which is, per patient is relatively expensive, but was able to kind of encourage lawmakers and policymakers to use money from the government to help pay for these surgeries. And so he's done many, many surgeries. And, together with Pen Plus, this is a structure to help identify patients with rheumatic heart disease that need that surgery, as well as take care of them clinically after their surgery. So they work very well together. Your question about using ACE inhibitors and angiotensin receptor blockers, those medicines are, very evidence-based for cardiomyopathy, specifically like heart failure with reduced ejection fraction, where they lower mortality, improve symptoms. So they're very, very useful. But you're right in that they can cause changes in creatinine, changes in renal function, as well as hyperkalemia. In our experience, for the patients who have normal kidney function to start, it's extremely rare that they would develop a rise in creatinine enough to where you would need to stop the medicine just by that. So actually, in a lot of places, obviously, ideally you would be able to check their basic metabolic panel after starting a medicine, but some places it's not an option, right? It's either too costly, patients can't afford it, your analyzer's out of reagents, your cold chain supply hasn't been working, so you don't have reagents. So there may be barriers to this. Personally, I don't really think it's something that should limit our increasing of those medicines, particularly in people with whose renal function is normal to begin with. For those who have also chronic kidney disease with their cardiomyopathy, with their heart failure, then it gets more challenging. Most of those patients should be able to be on like a mid-range dose at least. Lisinopril 20, enalapril 10, losartan 50, something around there, without causing too much rise in the creatinine just from the medicine itself. But yeah, I think you need to be a little more careful in those who have coexistent kidney disease. Yeah. I also tell people, because there may be a lot of other GI or diarrheal illnesses out there. I ask them to like stop taking it when they get diarrhea, because then they can get dehydrated and cause acute kidney injury, in addition to keep taking the ACE inhibitors that can cause more challenges. And usually they're just not taking it for like a couple days until their acute diarrhea is over.
Thank you. Thank you.
Excellent. Any other questions from our other panelists?
Yeah, hello, Dr. Kwan. This is Dr. Chinda from Cameroon.
Hello.
Yes,
Hello,
let me
Dr.
start by
Chinda.
saying how fascinating your presentation was. And a few times you wondered about how it's going in Cameroon. And the truth is, it's going exactly like you presented it. We first of all do see a lot of cases of rheumatic heart disease. And it is a really common etiology of heart failure, both in young people, but even older patients. And the health services here in Cameroon is subdivided a little bit like what you presented in Rwanda. We have about 180 to 190 health districts, under which you have a lot of hospitals. And then you have an intermediate level where you have the regional delegations, about 10, one per each region in Cameroon. So a lot of times we do have quite a few cardiologists. I would say about 50 to 100 for 28 million inhabitants. But a lot of the patients in the rural areas cannot have access to these cardiologists. So it was quite fascinating to hear your experience training nurses on the focused cardiac ultrasound. And it was reassuring to find out that you had a situation analysis in Cameroon. So we are probably going to get to the point where we do get to have our patients here benefit from, our nurses benefit from that training, and our patients benefit from that care. So it was quite, encouraging and fascinating to hear that the level of agreement following the cardiac ultrasound performed by these nurses and cardiologists was higher than 80, 90%. So that was quite impressive.
Yeah, we're definitely able to train nurses to do the skill. I'm a cardiologist, an echocardiographer. The vast majority of my interpretation on an echocardiogram is not needed for clinical care. So like, we will say like, oh, the atrium is like this size or that size. Most of the time that doesn't really impact the care. And so we've tried to distill it down to what are the major things that really change care, and kind of distilled it down to like 4 or 5 different features on echo. And we have noticed, so it is possible. One thing we have also noticed is that people lose skills over time, just as anybody does. If they're not using a skill frequently, they can lose those skills. So having some type of mentorship even after that initial training is really important to keep the skills, to maintain those skills. And we've done mentorship remotely, using image case banks, or clinicians will just present the cases that they've seen recently, and other clinicians can learn from them about how their approach was. We'll review their echocardiograms and give pointers and say, oh, you can improve your quality by doing X, Y, and Z. So there are different ways to help with that mentorship, even without being like side by side with somebody.
Well, thank you, really.
Yeah.
Thank you.
Yeah. I'm curious for the in Cameroon, the physicians, you yourself or the others in the room, what level of physician are you?
Well, we have quite a few internists in the room right now, and residents in internal medicine from level 1 to 4.
Mm-hmm. Got it. Wonderful. Yeah.
Excellent. And any other questions from any of our panelists?
I see something in the Q&A. I'm trying to figure this out. Dr. Kumar asked, do you have plan for focused echocardiography training for nurses and medical officers in Sierra Leone? Yes, we are. So in Sierra Leone, we're in that phase 3 pilot kind of implementation in 2 places. One is in Kono district, and then another is I think a place called Pujahun, which is also in rural Sierra Leone.
Excellent. And well, thank you again, Dr. Kwan. This was fantastic. I have learned a ton, and it's very, very warming to see that our efforts are extending on the global scale. With that, I think we will wrap up our webinar. Thank you again.
Thank you. Yes, well said, Elliot. And thanks, Dr. Kwan. I just echo Elliot's comments there. Great to have your perspective on sort of advancing public health infrastructure, as well as we think about sort of, resource not so rich settings, like ours, and challenges, and sort of a firsthand view. So something that our collaborators, I'm sure, really appreciate as they're trying to think about population health and in the regions that they serve. So yeah, if anyone else, from our international collaborating team, if you want to set up a meeting, or we're happy to facilitate a meeting and see if there's opportunities to collaborate and do some implementation in your area as well, for education and so forth. We're happy to be partner in that. But thank you again. Thanks again, Dr. Kwan. Yeah.
Yeah, thank you for having me, and have a good afternoon or morning.
Yes.
Or evening,
All right.
for Dr. Maskey.
Yes. Good night. Good evening, Dr.
Okay.
Maskey, and welcome again, our colleagues from
Good
Nepal.
night.
Nice to have you all. Yeah.
Good night, Dr.
Nice
Ankur.
to
Yeah,
see
hi.
you, Dr. Maskey. Yeah. Hi.
Yeah,
Nice to have
yeah,
our team from Nepal coming in
my
today.
pleasure.
All right. All right, Dr. Shinda and team in Cameroon, have a nice evening.
Thank you very much, Dr.
Mhm.
Anko.
Bye
Okay,
now.
bye-bye.
Bye. Bye.
Bye. Take care.